Absolutely, absolutely a learning platform. And feel free to ask me any questions. I would be glad to answer all your queries. All right. And this is absolutely the guideline based coaching. So nothing is from my side. This all everything from the standard book. But we'll discuss a lot today definitely. And those who miss, though, they can get the video recorded. But live recording 110% they are missing the live class. So without wasting the time, we'll just have a quick review of this medical MCQ. I'm Dr. Munjal Pandya. For those who are joining first time, I'm a hemato-oncologist and bone marrow transplant fellow practicing close to 20 plus years now. And I have a rich experience of treating more than 100,000 patients and coaching experience of more than 10 years, especially hematology oncology is my key area of interest. Dr. Arti is our consultant pediatrician. She is also excellently delivering the lectures every day. Dr. Maddie, she is a consultant, this internal medicine guy based at Oman. She is also mainly interested in cardiology, so deliver excellent lectures on cardiorespiratory, endocrinology, and internal medicine subjects. Dr. Ankit Patel is a consultant gastroenterologist based at my city, Ahmedabad, and he will uh, going to deliver you all GI lectures. And Dr. Shikha, who is based at Dubai in our team, conducting classes regularly on gynec now. From this month, she will be very much active. So this is all our limb. Dr. Deepali Patil is also there, who is a consultant gynecologist, and our backup team. And three new youngsters has been joined already since last month. Dr. Mariam J. Hillard is neurologist based at US, California. Dr. Sonal Shah, who is a consultant emergency physician in a reputed hospital in Mumbai, India. And Dr. Ismail is a surgeon. So this is all our excellent team who is delivering the classes daily. Another good news, those who are interested in book, I am updating this book. So probably in a month or two, you're gonna get the new version of this book, PROMETRIC 1000 MCQ book. This is all subject wise with answer and uh, explanations. Many pictures are added, and whatever the small suggestions and the things were there, it was also updated. So that is the new things and lots of mega offers offered by Medical MCQ for all. So you can inquire later on. So you get the latest update of that as well. So this is what the thing is. So let's start without wasting our time. Last but not the least, let me cover a couple of more slides. Those who are bit new doesn't know about this YouTube channel, excellent YouTube channel. You must subscribe it. More than 6, 7,000 doctors already been joined. So you gonna get the updated videos on this channel of Medical MCQ for all. So you just go through it, and there are a few things we'll discuss later. So let's start with the main subject of our things. Concentrate well on the every questions. Every word is important, and this is how it comes in the exam. Never a one liner. So many people are used to prepare with one liner question. So believe me, there is not a single line or one liner question. Absolutely scenario based questions. Whichever exam you are giving, it's all scenario based exam. So try to do the practice from day one, right, with the scenarios. So 63 years old man comes to the physician because of increasing generalized fatigue for 3 months. He is having more difficulty in breathe, more difficulty with keeping up with his activity of daily living and lost 2.5 kg over the past month. He has a hypertension and hyperlipidemia. He does not smoke and drink. He does not smoke and drink 2 to 3 beers on weekends. His medication includes lisinopril, hydrochlorothiazide, atorvastatin. His temperature is 98.8 degree Fahrenheit. Pulse is 85 per minute. Respiratory rate is 15 per minute. Blood pressure is 125/73. examination shows pale conjunctiva. The remainder of the examination show no abnormalities. His hematocrit is 27%. Leukocyte count is 4,500 per cubic millimeter. Platelet count is 102, means 1 lakh, 2 lakh, 2000 or 102,000 per cubic millimeter. Peripheral blood smear shows numerous blast cell, which shows the stain positivity for myeloperoxidase CD33 and CD34. Which of the following is most likely diagnosis? Is it AML? Is it non-Hodgkin's lymphoma? Is it hairy cell leukemia? Is it chronic lymphoblastic leukemia or acute lymphoblastic leukemia? So your time starts now. You think of your diagnosis. Those who joining first time, I'll give you the triad. This is MCQ. So this is MCQ. You think over it. Meanwhile, I'm giving my this high yield point. You need to know three things: diagnosis, investigation, and treatment. So right now, what they are asking is the diagnosis. Once you make a diagnosis, we'll jump on the investigation. We'll also jump on the treatment. So in one MCQ, if you do it thoroughly and sincerely, you will solve three MCQ every day. So you multiply. If you are 25 MCQ you are doing, that means you are doing 75 MCQ. Multiply by three. Why? Because we need to get answer of three: diagnosis, investigation, and treatment. So you can post your answer in the chat box. Now you have an excellent facility having a chat box, right? So you can post A, B, C, D, and then we'll discuss. I mean, how you think, what's your thought process, right? So you can post your answer. And let me tell you one more thing. You have hardly 1 minute for one MCQ. So you need to do a practice, sincerely practice, right? This class is absolutely, I mean, exam oriented. So I'm not trying to scare you here, but I'm trying to give you the real idea. So you need to work little hard on yourself. Yes. Anyone? Fine. So one answer is A. Let's see. What's another answer? A. Let's see. Yes, Dr. Rita. You can open up your mic, Dr. Rita. Are you there in the
Hello.
class?
Yes, yes, sir.
Yes. So now
Can
tell
you hear
me.
me?
Yes, yes, I can hear you very well. So yes, Dr. Rita, just for the discussion purpose, don't take it otherwise. Just interact. You posted the answer hairy cell leukemia.
Oh,
So
sorry, it's D. Actually mentioned CLL. Sorry, it's
okay, so
D.
your answer is C, D, or E.
D.
D.
Chronic lymphocytic leukemia.
Wonderful, excellent. So now let me ask you, what things, right? What things to make you think of chronic lymphoblastic leukemia? Let's discuss one by one, all right? Because I told you we'll solve 50 questions. So let's start. So now tell me, doctor, what point favors CLL in this scenario? Start.
So is first of all the age.
I'll write down everything. Whatever you explain me, I'll write down everything. No problem. So tell me, what is the first point which favors the CLL?
First of all the age of the patient.
Okay, great, wonderful. So CLL is the age of the patient. So it is a disease of 60 to 70. So here the 60, that one point favors the CLL. Excellent. What else?
The peripheral smear blast cells and the positive for the myeloperoxidase.
So peripheral smear shows blast cell. Okay. Okay. So how many
And
blast cells? What is the definition of blast cell? Right? What is the definition of blast cell, or how much amount of the blast cell you need to tell that it is a chronic lymphoblastic leukemia? Can anyone tell me what is the amount or percentage of the blast? That okay, fine. 10% of blast it is CLL, 15% of blast it is CLL. So what percentage of the blast cell? Yes, Rita.
I think 15, not sure. Not sure.
Okay, what's in your mind? Whatever is in your mind, I'll write down here. Fine. So forget about number of the blast cell present. Okay, fine. What else it favors? So one is age,
Sir,
by you
other
it's
symptoms
peripheral
as
smear
well.
blast, like which symptoms?
Sir, weight lost, and
Weight loss.
just a second. So, and the hematocrit is 27% now. So,
Yes,
fatigue,
it
that's
is
why
here.
is fatigue.
Yeah, fatigue is there. So probably it's anemia, na? Low hematocrit is anemia. So low
Yes,
hematocrit. So now can you tell me what is the definition of CLL? How you diagnose CLL? If you have a one patient of CLL, or what are the key points of CLL? Key points of CLL. Forget about this scenario. Key points of CLL. So
yes,
let me tell you key points of CLL. It's a disease of elderly people, 60s plus, usually CLL we see, right? This is a
yes,
leukocytosis, and in leukocytosis there is an increased lymphocyte, right? We'll check later on. So leukocytosis means normal WBC is 4,000 to 10,000. So this patient should have high total count or WBC count with high lymphocyte, right? High
yes, sir.
lymphocyte. This patient's incidental detection. This is the most commonest malignancy in elderly people in Western and Indian worlds. I'm treating this CLL for almost close to 20 years. So I'm giving you my general experience of last 20 years of CLL. So it's an incidental detection. Means they gone for renal stone and they came back with CLL that oh renal stone is there, but your count are 15,000, 90% are lymphocyte, you are CLL. Is that clear? So that is called incidental. They may have
Yes,
lymphadenopathy, they may not have. They have a hepatosplenomegaly or not. They have reduced. They in advanced state there is a anemia, and in advanced state there is a thrombocytopenia. Diagnosis is done by the flow cytometry, right? Where you see the BCLL is the most commonest type, and in BCLL, you get CD20 positive, sometimes CD10 positive, and other markers, which is not here, which is not here. So this is not a CLL. The point against CLL, let's go one by one. Number one thing is patient has a normal WBC count. You keep your concentration, Dr. Rita, here, so you get to know what the real things are going on, right? Leukocytes are
yes, sir.
normal.
Yes, sir.
Leukocyte normal, right? CLL usually they have high
Correct.
WBC count or leukocyte count with increased lymphocytosis, right? So say for example 15,000 WBC count and 90% of them they are lymphocyte. They have not mentioned anything. In peripheral smear of CLL, there is a mature looking lymphocyte, and there is a smudge cell. Have you heard of smudge cell? Yes or no? At least tell me yes or no. So I thought you are with me.
Yes, sir.
Yes or no? Right? So smooth cell.
Yes.
So nothing is there. Myeloperoxidase is a enzymes for myeloid series, not the lymphoid series. It is not a lymphoid series marker. Myeloperoxidase. Myelo means myeloid. Remember in that way. Myelo means myeloid. Myeloperoxidase. Myelo means myeloid series, not a lymphoid series. So lymphoblastic leukemia arising from lymphoid series or lymphoblast, not from the myeloblast, right? And you never ever see CD33, CD34, and myeloperoxidase positive in CLL. So CLL is out. Is that clear? Yes or no? Anybody has any questions? I would be glad to
Yes.
answer. Is that clear? Yes or no?
Yes, sir.
Dr. Reena, you got the idea. So this is gone. This is gone. Now we have a four options, right? So let's try another options. Anybody wants to try another option, they can try. I given you the clear cut explanation of not CLL, right? And you never see a blast. Usually, you won't see a blast in CLL, just for your kind knowledge, Dr. Rita. So, blast usually seen in acute leukemia in peripheral smear. They are saying peripheral smear. So, blast cells is always think of something bad leukemia, all right? Spilling of the blast cell from the bone marrow to blood. It is usually seen in acute leukemia. So in that way, usually blast cells are zero. No blast cell seen in a chronic lymphoblastic leukemia or chronic myeloid leukemia or hairy cell leukemia in the blood, especially the peripheral. Usually. So it is gone. Right. So now, any next thought or any next this understanding? Anyone? Yes, anyone? So CLL is gone. Now, what could be the next answer? Come on, you can post yes or no, no problem.
AML.
There are more than AML. Oh, okay, AML. Yes. Anyone else? Dr. Pratibha, are you
AML,
there?
sir. Yes, sir. AML.
AML. So, what do you think, or what makes you to think of AML? What are the point favor in the AML? This is how you have to practice for each and every MCQ, not this MCQ, AML, right? So, I'm happy if you can give me the point favoring the AML. So, your answer is AML, acute myeloid leukemia. So what point favors the AML? The way we excluded CLL, why it is not CLL? Blast are not there, no blast in the peripheral blood, right? There is no CD33, 34 myeloperoxidase should be there, blah blah. So what do you think? What makes you to think of AML, Pratibha?
Uh, because myeloperoxidase is positive, sir. It positive in acute myeloid leukemia.
Excellent.
Uh,
So this is one point. Myeloperoxidase is positive in myeloid leukemia. What else?
the symptoms are increasing. Uh, it more favor of acute phase of leukemia.
Fine. So one is MPO. What else? Symptoms could be same in most of the leukemia, acute, chronic. They may have fever, fatigue, right? Weight loss. These all are the constitutional symptoms. That will not give the diagnosis. The diagnosis either in the CBC or in the peripheral smear, bone marrow, or flow cytometry, right? So what do you think? One is MPO positive.
Blast cells are there.
No problem. You think over it. Yes, Dr. Nagin. Any comment? Dr. Nagin, Dr. Akbar, Dr. Babar, Dr. Boni, Kainath, Tushar. There are a lot of doctors, close to 30 doctors join already. Yes, anyone wants to comment? It's a commonest malignancy. All five things are very common in the clinical practice. So if you are in hemato-oncology unit, this is very common questions, very common this presentation of lots of patients.
So in
So
peripheral blood smear, there is numerous blood cell positive with myeloperoxidase.
great, wonderful, wonderful. So if I can ask you, Dr. Babar, why it is not a non-Hodgkin's lymphoma? Why it is AML? Why it is not non-Hodgkin's lymphoma? In lymphoma, you get generalized fatigue, you get anemia, right? You may get low platelet because of bone marrow involvement, right? Why it is not a non-Hodgkin's lymphoma then? Why it is not
Because sir, in
leukemia?
NHL we will most likely seeing the lymphocytes.
Okay, fine. So one is in lymphocyte you see in this thing. Then I can say why it is not ALL then.
ALL is usually we seeing in the patient in the first line of the patient age is given. So
Okay,
most likely
excellent. So
ALL
one
is for
one is
the
the age is pediatric age group, which is not there here. Okay, one point. So what else? Only the age is there
कौन
or any other things?
है अच्छा एक मिनट
Age, yeah, anyone can speak anything. Don't worry. This is learning platform. That is how you can clarify your thought process. Age, I have seen the patient who developed the at the age of 63, they develop ALL. I have patient. I am treating it. Obviously, in last 20 years, I must treated all age extremities. So age is one of the factor, but not the all the things. So age is just the one clue towards the diagnosis. but absolutely not the whole and sole thing that, oh, age 63, that does not mean, right? If I can tell you there is a more than 25% of the blast cell and flow cytometry is suggestive of ALL, then it is ALL, obviously. But in ALL, apart from the age, MPO is negative, myeloperoxidase is negative. It's a myeloid marker, not lymphoid marker, right? And CD33 and 34 absolutely not seen in ALL. There is a, right? So ALL is not there. See, this is excluded. Non-Hodgkin's lymphoma, lymphocytosis, B symptoms, fever, night sweat, and weight loss. Absence of Reed-Sternberg cell, absence of Reed-Sternberg cells in lymph node or tissue biopsy or excisional lymph node biopsy, right? There is a no obvious lymphadenopathy, no hepatosplenomegaly, or no clue, and you cannot see blast in the non-Hodgkin's lymphoma. Blast is absent. Here they are saying blast in the peripheral smear. CD34, 33, and 34 is negative in non-Hodgkin's lymphoma. Myeloperoxidase is negative in non-Hodgkin's lymphoma, and same things applies to the non whatever applies to the non-Hodgkin. Same explanation for hairy cell leukemia. Why the name comes? There is a hair-like projection on the cell. So this is a cell, and there is a hair-like a projection. If you see and you do bone marrow, we recently diagnosed 2 months back one patient presented with pancytopenia. So hairy cell in the peripheral smear or bone marrow, splenomegaly, pancytopenia. Here there is no pancytopenia, only, right, normal, just for your knowledge. There is no huge splenomegaly, right, in the things. So these are the classical points. So this is none other than acute myeloid leukemia, because acute myeloid leukemia fittings all the things what is mentioned in the scenario, right? Everything fits to the AML. So diagnosis here is AML, acute myeloid leukemia. So can anyone tell me head-to-head comparison how you differentiate AML from ALL? Then, if I can ask you, how you differentiate AML from ALL? Anyone? So let's go to the real literature, right? So this is real literature. AML, acute myeloid leukemia. Before I jump, let me draw beautiful picture. This is hematopoietic stem cell. Hematopoietic stem cell will give rise to myeloblast, and another is a lymphoblast, right? This myeloblast will give rise to everything. Let me have one insert one slide to get you the better understanding. New slide. So this is a hematopoietic stem cell give rise to myeloblast, and another is a lymphoblast. Lymphoblast will give rise to only two things, three things rather: B lymphocyte, T lymphocyte, and natural killer cell, NK cell. Right? These are the three things generated from the lymphoblast. And myeloblast give rise to everything. One is a RBC, another is a platelet, and third thing is the WBC. WBC contains neutrophil, eosinophil, basophil, and monocyte. So before RBC production, there is a reticulocyte count. Retic will generate. Before platelet, there is a megakaryocyte which generates platelet, and there is a long promyelocyte, myelocyte, metamyelocyte, band cell, and then neutrophil. So I'm not going much in detail on how it's developed, right? So you must have very much clear-cut idea in your mind what generated from the myeloid series and what generated from the lymphoid series. This is myeloid series, right? So RBC, WBC, except lymphocyte and platelet. So most of the cells is generated from the myeloid series, and this is that, right? So this you must know, right? This is basic, right? So when there is a more than 20% of the blast cell of myeloid origin, more than 20% definition, WHO definition of acute myeloid leukemia, more than 20% of the myeloblast in peripheral blood or bone marrow is acute myeloid leukemia. That's it. Simple definition, right? Because myeloblast normal, you should supposed to know less than 5% is normal. Lymphoblast less than 5% is normal. So lymphoblast, if it is more than 20% in peripheral blood or bone marrow is ALL. More than 20% of myeloblast in peripheral blood or bone marrow is AML. Is that clear to everyone? At least tell me yes or no. At least tell me yes or no.
Yes, yes, sir.
Wonderful, wonderful. Right. So this is a definition of WHO definition of leukemia. So first, acute leukemia, you don't need to mug up more than 20% of the blast. Then your second question, which blast? Myeloblast or lymphoblast? If myeloblast, acute myeloid leukemia. If more than 20% of blast, lymphoblast, acute lymphoid leukemia. Is that clear? Yes or no?
Yes, sir.
Wonderful. So this is the basic. So acute myeloid leukemia, right? Here, as I told you, so this is a head-to-head comparison. So here, obviously, more than 20% of the myeloblast, and here more than 20% of the lymphoblast. That is how it comes definition by WHO is acute myeloid and lymphoid. There are various way by which you can differentiate AML from ALL. Number one is immunohistochemistry. So you do some chemical test or immunohistochemistry where MPO is positive. MPO is positive. It is none other than AML. Is that clear to everyone? Yes or no? MPO is positive. Here the MPO is negative. In ALL it is negative. So if you stay right with the MPO, right? It is biochemistry or immunohistochemistry, right? So this is positive and TDT and pass is negative. Reverse here, the TDT and pass is positive. Is that clear? Yes or no? So you need to do three tests, right? You ask for the myeloperoxidase, you ask for the TDT, and you ask for the para-aminosalicylic or pass test. In AML, this is positive, this two negative. In ALL, this is negative, this two is positive. Is that clear to everyone? Yes or no? At least tell me yes or no.
Yes.
Wonderful.
Yes, sir.
So in scenario, they have mentioned blast cells are MPO positive. Is that clear? So this is myeloid, MPO positive, myeloid, acute myeloid. So this is one way. Second way, flow cytometry, also known as immunophenotyping or flow cytometry, same thing. What is the meaning of that? Let me give you a little clarity. Every cell, whether it is a myeloid or whether it is a lymphoid, on the surface there is a marker called as a CD marker. CD stands for cluster differentiation. So this is genetically, right? This is a unique for the individual. On the surface of the cell there is a cluster differentiation, and this is a specific for neutrophil, myelocyte, lymphocyte, all the cells in the body. So this can be identified by the flow cytometry. So by putting the markers, by doing the flow cytometry, you identify the, whether it is a myeloid or whether it is a lymphoid or whether it is a myeloid. So what are the myeloid and lymphoid? How did we get to know? Right. So B cell, if it is a BALL or acute lymphoblastic leukemia from B cell origin, right? If you remember my old picture, right? The lymphoblast will give rise to lymphocyte, right? B lymphocyte and T lymphocyte. So how did you get to know by flow cytometry B lymphocyte and T lymphocyte? So there are markers. So CD10, 19 and 20. These are the B lymphocyte or B lymphocyte marker. What are the T lymphocyte marker? 2, 8 and 3. So I remember as 238. This is how I remember being a clinician. CD2, CD3, CD8. This is T lymphocyte. That's it. That's it. Is that clear? Yes or no? Yes or no?
Sir, please repeat it.
Yes, sir. Yes, sir.
So on the surface of say this is the lymphocyte. You don't know whether B lymphocyte or T lymphocyte. So
Yes.
on the surface, right, there is a cluster differentiation by which immunophenotyping you get to know. If it is a CD10, If it is a CD20 and if it is CD19, it is B lymphocyte. So if this leukemia, you don't know which leukemia, ALL, you know more than 20% of blast, all are lymphocyte, but you don't know B or T. Then put a marker. If it is CD10, 20, and 19s are there in the flow cytometry, it is B lymphocyte, right? CD2, CD3, CD8 are there on the cell, it is T lymphocyte. Is that clear? So final diagnosis is
Yes,
BALL.
sir, it's clear.
Final diagnosis is TALL. Why? Because in T, 238 is positive, rest all negative. In B, 10, 19, 20 positive, rest are negative. So this is B and T lymphocyte. Is that clear? Yes or no?
Yes, sir. Yes, sir.
Yes, sir.
Wonderful.
Yes, sir.
In a myeloid, there are CD13, CD33, 34, 117, HLA-DR. Ideally, let me tell you, this is not exactly your job to remember this all CD, but for the knowledge purpose, I'm trying to explain you so you know when you read the AML report in your clinic, right? When somebody did a bone marrow, right? Your senior colleague and say, oh, this is AML. So you must know what is AML, how does it AML, what markers are positive, right? So this is ideally a job of histopathologist, right? Histopathologist. They will give me the idea, right? That okay, sir, this is BALL, this is TALL, this is AML, blah blah, right? But we should know. Being a clinician, we should know, right? So this is the things. Is that clear so far? Yes or no? At least tell me yes or no. So far, it is clear or not?
Yes, sir. It is clear.
Yes, sir.
Yes,
Wonderful,
sir.
wonderful, wonderful, brilliant, right? So this is the one differentiating point, right? And this is cytogenetic. Let's come to the cytogenetic. So in cytogenetic or chromosomal analysis, if you go, right, you don't need to smug up everything, but you need to know, right? Right? In B, common in a hyperploidy. Hyperdiploidy is common. Philadelphia translocation is common in ALL. So Philadelphia chromosome. Do you know what is Philadelphia chromosome? PH chromosome? Yes or no? Yes or
No,
no?
sir.
Philadelphia chromosome.
No, sir.
No, sir. Okay. So let me give
No.
you a quick idea, right? So there is a cell in the cell nucleus. Within that nucleolus, so when there is a right, when there is a cell divides, there is a 23 pairs of the chromosome that you must be knowing, right? 1 2 3 4 5 6 7 8 9 and 23 pairs of chromosome. Yes or no? Right, so
Yes, sir.
23 pairs of chromosome is there. So 23rd chromosome is called as a sex chromosome. Female has a XX and male has a XY. Is that clear? Yes or no?
Yes, sir.
So when there is a translocation in 9 and 22, so 9 number of chromosome and 22 number of chromosome. So some part of this is normal 9 for your knowledge, and this is 20, just for your brief idea. So what happens? Some part of the 9 chromosome going into the 22, and some part of the sorry 22, right, going into the 9. So there is a translocation. 9 chromosomes, some part going to 22 and 22 chromosomes going into the 9. So there is a one gene, mutated gene is developed, and that is called as the Philadelphia chromosome. Philadelphia chromosome. And this Philadelphia chromosome, and there is a one gene called as a fusion gene developed, that is called as a BCR able, right? So part of the able from 9 and part of the BCR of 22 going here, and this is going here. So one gene is developed called as a BCR able gene, and there is a one drug which blocks this gene, oncogene, is called as the imatinib, and that is a drug of choice for CML. Is that clear? Yes or no? Is that clear? Yes or no? Yes or no?
Yes, sir. This part is clear.
Wonderful. So this is called as a Philadelphia. So somebody asking me, sir, what is Philadelphia chromosome? So this mutated chromosome, right? The translocation from 922. So it's a absolutely high yield question in the exam, right? How you diagnose CML? right? So presence of Philadelphia chromosome is pathognomonic of CML, right? So this is shortly about the CML, how it's developed and how it's done, right? So PH chromosome you can see in ALL, and last but not the least, right? So this is all little prognostically important, right? So few other, and this is the last slide I created by my own. It is not in the picture, not in the book, but you can have this picture. You can take a picture. I don't mind. This only one slide will clarify all four things. Very simple, very understandable way, and very easier way. So what is AML? So AML is 20% of the blast. As I told you, which blast? It's a myeloblast. Simple. ALL 20% of the blast. Yes, but which type of blast? Lymphoblast. Clear. This is ALL. As we know, CBC usually how they present AML, pancytopenia, thrombocytopenia is striking features, right? It can be seen in a middle age, usually in the middle age, older age as also AML commonly seen. This is pediatric age is commonly you see ALL, and that is why age is important. So whenever you are solving any leukemia patient's MCQ, look at the age, look at the blast, look at the patient's age. CNS involvement is very common, right? In ALL, which is absent or which is not seen neurological involvement in AML. So, child presented with the pancytopenia, splenomegaly, neurological symptoms, it is none other than ALL. But how do we get to know until and unless we know the clinical vignity of the patient? Usually, high total count with increased lymphocyte, and splenomegaly and lymphadenopathy is also common, which is not commonly seen in AML. This is another differentiating point. Or rods is pathognomonic of AML. Somebody will ask me, sir, what is OR rod? So let me tell you, this is a cell, right? Myeloblast. This is nucleus, right? And in the plasma of in the plasma, or sorry, in the cytoplasm, there is a rod-like a structure. This is a rod-like a structure. This is called as AUR rod or OR rod. And OR rod is equal to AML. Write down in your notes. Whenever you see any scenario which mention OR rod, don't read anything. Whatever they mention, 5 years of age, pediatric age, splenomegaly, no splenomegaly, lymphadenopathy, this much of blast, that much of blast. Forget about everything. Remember, if you see in scenario OR rod, click the answer AML. That's it. As simple as that. Is that clear to everyone? Yes or no? At least tell me yes
Yes,
or
sir.
no.
Yes, sir. Yes,
Yes,
sir.
sir.
No OR rods in ALL, no OR rods in CML, no OR rods in CLL. What does it mean? Presence of OR rod is AML. That's it. Again, what is faggot? Multiple OR rod. Multiple OR rod in a bundle is called as a faggot, for your knowledge. One OR rod, 10 OR rods is faggot in general. So faggots are present. MPO already we discussed. Myeloperoxidase is present here, right? Here myeloperoxidase is absent. What is present? Past present and TDT present. TDT present. Here negative. CNS involvement in AML, no. It is commonly present, yes, right? Not going much here. Same way CML, how you differentiate CML? Number one thing in CLL, usually in the middle age group, striking features, a middle age group, increased total count, neutrophil will increase, splenomegaly is seen in more than 90% of the patient. If you remember this much, you can diagnose CML. Middle aged, total count increase, not lymphocyte. In CLL, lymphocyte increase. In myeloid is neutrophil. I already given you the picture, right? So myeloid will give rise to neutrophil, eosinophil, basophil, and monocyte, not the lymphocyte. It is lymphoid series, right? So neutrophil increase, splenomegaly, right? So right. So they usually have high count, as I told you, high count neutrophil. Yes, neutrophil, splenomegaly. This is more than enough for you to know. Chronic lymphoblastic leukemia, it is a disease of old age, number one. Commonly, I have seen the patient. We recently did a bone marrow transplant of a patient who has a 35 years of age with CLL. So age is not always the only criteria, but usually yes. If you go through the epidemiology, age and sex does matter. So old age usually say increased total count. In CML also increase total count. What's the difference between CML and CLL? Here increase neutrophil, here increase lymphocyte. Is that clear? Yes or no? Yes
Yes.
or no?
Yes, sir.
Wonderful,
Yes.
Yes,
wonderful. So this
yes,
is
sir.
lymphocyte, right? So this is the thing, right? So this is a general head-to-head comparisons of both AML, ALL, CML, and CLL. So you just need to keep in mind. I have hundreds of things to tell you, but not going in much detail because we are, I mean, not trying to give the hematology exam, right? But if you have interest, we will cover later on what's the treatment, prognosis, blah, blah. But I know I'm doing this job for last 10 years, coaching, guiding, teaching, mentoring to several resident in the hospital as well, DNB students for hematology day to day. So whatever the important for you to know, I'll just giving you that only for the exam point of view. So that's it. This is what the AML, right? Acute leukemia, AML, ALL. I told you everything. This is all sign symptomatology. So this is the final explanation. As many as the name implies, acute myeloid leukemia is caused by the mutation in the bone marrow in the stem cell. As I told you, myeloblast versus lymphoblast. That is a mutation developed, right? And there is a right. The number of the blast cells. Acute leukemia generally causes rapid, this more rapid and severe evaluation of blast cell. No need to, not much important. Anyway, so this is AML. Myeloperoxidase is positive. CD 13, 33, 34, and if this you see positive, it is AML. That's it. ALL, why it is not ALL? I already told you this all are negative. MPO is negative. These all markers are. So what is positive in acute lymphoblastic leukemia? If it is a B cell, right? 10, 19, 20, and if it is T cell, 2, 3, 8, and few other markers are positive, right? So this is what the thing is. This is all explanation. Why not non-Hodgkin's lymphoma? I told you hairy cell leukemia and chronic lymphoblastic leukemia. Any questions to this MCQ? Anyone? This is the original MCQ. Any question? Any
No,
question?
sir.
Is it clear to all?
Yes, sir.
Yes, sir. It is clear.
Wonderful. So I'll switch to the next question. So let's change your gear from hematology to another MCQ. So now, yes, this is second questions in front of screen. We'll definitely solve 10, 15 questions in this as well, like last question. 4 days after admission to the hospital for community acquired pneumonia, 68 years old woman has abdominal pain and multiple episode of loose stool. There are They are watery, foul smelling, and occasionally sticked with blood. She has approximately 6 episodes daily. She feels tired. She is currently being treated with intravenous ceftriaxone and oral azithromycin. She underwent a laparoscopic cholecystectomy 5 years ago. She has hypertension, type 2 diabetes mellitus. Current medication includes metformin, enalapril, and clothianidone. She returns from a trip of Bolivia 4 weeks ago. Her temperature is 37.5, pulse is 98, blood pressure is 138 over 80. Bronchial breathing sounds are heard over the right lung. Abdominal examination shows mild diffuse tenderness throughout the lower quadrant. The abdomen is not distended. The remainder of her examination shows no abnormalities. Her hemoglobin concentration is 12 gram per dl. Leukocyte is 14,100 per cubic millimeter. Erythrocyte sedimentation rate or ESR is 37 millimeter per hour or at 1 hour 37. Which of the following is most likely next step in the management? Stool for ova and parasite, fecal lactoferrin, stool toxin test, CT scan of abdomen and pelvis, blood culture, sigmoidoscopy. Take your time. Take your time. Don't be in a hurry. Take 5, 10, 15 seconds. Again, I start my MCQ with the triad. So first of all, you need to make some kind of differential diagnosis. If you can able to make this, your job is bit easy. They are not asking this diagnosis. They are asking management or how you gonna approach, right? So without diagnosis in your mind, what is the diagnosis? It is ulcerative colitis, Crohn's disease, or some GI infections, or something else, or some food poisoning, or some GI things, or whatever. Post your answer. Consider that this question will come in your exam. How you gonna respond? You don't just need to just keep and quiet. Sorry, I'm not trying to offend you, but just you need to think something. You
Sir, the answer would
post your
most likely
answer.
to be C.
Okay, great, sir. So we'll discuss. We'll discuss. Sir. Let me have more questions. I mean, sorry, more of answers in the chat box. Yes, we are 30 people and answer is three or four. That's it. Yes, Dr. Saikya, comment. Yes, able to speak. I would be glad. Yes, yes, Zahra Baba. Yes, anyone. What is the likely diagnosis? What do you think? What is the culprit in this?
So that is like freedom
Number.
deficit.
Yes, yes, Zahra. Go ahead. Going great.
Yes, I think it is Clostridium difficile. So the
Okay.
diagnosis should be stool toxin test.
Okay. So you think this is Clostridium difficile? Fine.
Yes.
So now, yeah, now tell me what point favoring the Clostridium difficile. So you think this is Clostridium difficile? Fine. So what point favoring here, which makes you to think of Clostridium difficile? Why not E. coli? Why not anaerobes? Why not other bacteria? Only C. difficile is why?
Yes, because it is a common complication after hospital admission due to
Oh,
use of antibiotics.
great.
Hmm.
So this is a antibiotic induced diarrhea. Am I right or
Yes.
wrong?
That is
Yes.
Wonderful.
correct, sir.
That's correct. So Clostridium difficile, it is an antibiotic associated diarrhea. Also another name is pseudomembranous colitis.
Correct.
These all are same thing. So you don't need to confuse yourself. Clostridium difficile, antibiotic associated diarrhea, pseudomembranous colitis, this all are the things. So here they are classically mentioned that patient has a community acquired pneumonia 4 days ago, right? 4 days after admission, 4 days after admission, right? For what? Community acquired pneumonia, right? Somebody developed this foul smelling, watery diarrhea, loose stool, multiple episode, not one episode, multiple episode of these things, right? And there is they have given the antibiotic name ceftriaxone and azithromycin, right? So ceftriaxone and azithromycin is a drug of choice for community acquired pneumonia. Another question in exam: drug of choice for community acquired pneumonia, azithromycin is a antibiotic, right? It is comes under the macrolide. Am I right or wrong? Macrolide,
Yes, sir.
right? So this is what the different antibiotic discussion. But anyway, uh, community acquired pneumonia, azithromycin. Have you heard of curb score? Curb score in community acquired pneumonia, CURBS, curb 65. Yes or no?
No.
Yes, sir.
So curve 65 criteria is another high yield question in the exam. So can anyone tell me what is the curve 65 criteria in this patient?
I don't
Anyone?
know, sir.
Yes, Dr. Rita, tell me what is the curve 65 criteria in this patient?
Sir,
It is
sir, C for
usually tell
confusion.
C for confusion. Excellent. C for confusion. First, tell me curves. Confusion.
Uh,
U for
U for uremia,
U for uremia.
respiratory rate,
Excellent. R for respiratory rate. B for
blood pressure.
and
C for
65.
65 is age. Age.
Excellent. So those who don't know what is a curve 65 criteria for pneumonia, you must calculate curve 65 for every patients of pneumonia. I'll give you why you want to know. What is the implication of it? What is the importance of it? I will tell you. So first of all, you must know, right, shortly known as a curve 65. It is given in all international book. Go open up the chapter. The pneumonia, you must see curve 65 score. So what is a curve 65? Confusion, uremia, respiratory rate, blood pressure, and age. So what is the score, Dr. Rina, here? If there is a confusion, score 1. If there is a confusion, no confusion, score 0. If there is a uremia,
Yeah.
score 1. If there is a no uremia, score 0. If respiratory rate is more than 30, it is score 1. If it is less than 30, score 0. Blood pressure, right? Blood pressure is low, score 1. Blood pressure is normal, score 0. Age less than 65, score 0. More than 65, 1. Is that clear to you or everyone? Yes or no?
Yes, sir.
Yes,
Yes, sir.
sir.
Wonderful. So they have not mentioned anything confusion. So score I can write down 0. Uremia
Zero.
they have not
Yes, sir.
not mentioned anything, score 0. Respiratory rate they have not mentioned anything. Respiratory rate should be score 0. Blood pressure,
So
hypertension
two,
is there. There is no
one.
hypertension 138. So it's a 0, na? Blood pressure should be
Yeah,
low.
zero, sir.
It is normal.
Sir, excuse me, sir. Sir, but he's taking the AC inhibitor for the hypertension. No? So
So
can we
so
give
so
it 1 point or not?
Usually at the time of presentation, hypertension is there, then you give one. If it is not there, though he is hypertensive, but blood pressure is under control, for your knowledge, right?
Ah,
Yeah.
okay.
So
Okay.
and age is 65 here. The age is 68. So you can count one. You
One
can
point.
count one.
One.
One point. All right. I will mute all. Sorry, you can interact with me. Anybody can interact with. I muted all because I get a lot of background. Somebody's talking behind. Anyway, so this score. Why this score is important? So let me tell you the curve 65 because that is also another question in exam. So if the score is 0, score is 1 or 2, right? If all points are there, 1, 1, 1, 1, 1, it's all 5 points, right? Maximum 5 point, minimum 0 point. Is that clear? Yes or no? So 0 is
Yes.
mild,
Yes, sir.
this is moderate, and this is 3, 4, and 5 is severe. Why we want to know? Mild can be outpatient department OPD, right? You have a pneumonia, community acquired pneumonia. You have seen SCORP 65. He's fine, he's walking, talking. There is no vital unstable, liver fine, renal fine, brain fine, kidney fine. You don't need to admit. Is that clear? Yes or no? You just give the azithromycin as outpatient and follow. That's it. Mild case, it's a subjective decision, either outpatient or inpatient. Inpatient depends on the patient's clinical condition. And 3, 4, 5 usually they are in ICU. The mortality in score 0 is less than
Sir,
5%.
can I ask a question?
1 minute, 1 minute. Let me finish. Yeah, you can ask any question. So mild, less than 5% mortality, here 5 to 10%, and in severe more than 20% of the mortality means death. So you need to closely observe such kind of patients while they are on the COP 65, and that is how it comes in the picture. Is that clear to everyone? First of all, yes or no?
Yes, sir.
Yes or
Yes,
no?
sir.
Wonderful. Now ask me the question. Someone wants to ask me the question. Ask now. I am
Yes,
at the
for score zero, we use azithromycin or amoxicillin.
community acquired pneumonia, usually azithromycin use. It depends on the country to country and local microorganism. But in general, if you go through the book, azithromycin is a well recommended drug for community acquired pneumonia.
Because I saw in the latest version of Master of the Board, it was amoxicillin.
Possible, as I told you, right? So which part of the world usually that mastered the board USMLE return is in United States of America by Conrad Fisher. So what organism is more pertaining to the US part? Probably that is not pertaining to the India where I live. You understand? So if I have some
So for
streptococcus,
the Gulf
for example,
countries,
streptococcus.
oh,
So let's see. We
no,
will see more literature. We'll see more literature. We'll see more literature, right? But
for
you
the
can also
Gulf
post.
countries, we can the answer is azithromycin.
Yeah. So overall, as of now, you keep
Okay.
answer azithromycin. Let me also talk to some of my colleague in Middle East and United States, right? What exactly they are giving,
Okay.
right, for the community acquired
Okay.
pneumonia.
Thank you.
But we go through the books as of now. Whatever is written in the book, that is a first answer. Then we'll see what is the local policy and guideline, right? So this is what the Cut 65, right? So uh,
Okay.
this is the taste. So now let me ask why, Dr. Rita, it is not fecal lactoferritin, and what is fecal lactoferritin? You must know, na, what is fecal lactoferritin. Anybody wants to comment what is fecal lactoferritin? Have you asked for this test anytime in your clinical practice? Okay, stool send for the fecal lactoferritin, like we send stool for occult blood, stool for routine microscopy, stool for culture, like that, stool for or fecal lactoferritin. Anyone? This all are questions in the exam.
No, sir. I'm hearing this for first time.
Okay, fine, no worries. Fair enough.
An
Yes,
inflammatory
anyone?
marker.
Sorry, Bonnie?
Inflammatory bowel disease.
Sir, it's an inflammatory marker to diagnose
Excellent.
inflammatory bowel disease.
Excellent. So this is an inflammatory marker. Fecal lactoferritin probably increased in inflammatory bowel disease. Don't confuse from irritable bowel syndrome and inflammatory bowel disease. So if you have confusion, go and read it. Right? It's a two different word, two different entity, do two different diagnosis investigation. Irritable bowel syndrome is different, and inflammatory bowel disease is different. It includes the ulcerative colitis, and Crohn's disease falls under the inflammatory bowel disease. So this could be increased lactoferritin in inflammatory condition of ulcerative colitis or Crohn's disease, where you get to see fecal lactoferritin. I'll give you more details on that as well in next 2 minutes. So just for the basic understanding, why you don't want to do the CT scan of abdomen and pelvis, right? CT scan of abdomen and pelvis will not give you much idea, right? And it will not give you the microbiological diagnosis. Microbiological diagnosis will not give by the CT scan. Even although CT scan you see some pseudomembranous blah blah or some obstruction or something, it is not the case. But right, and you are thinking of this, so you need to do something stool toxin test. Toxin means Clostridium difficile antigen. You can look for. It is one of the best test, right? Blood culture will not help. Clostridium will not grow in the blood culture, and sigmoidoscopy is invasive. And when you are suspecting some inflammatory bowel disease or ulcerative colitis or Crohn's disease or GI malignancy, probably it will help, but it will not that help that much in this case. Is that clear? Yes or no?
Yes, sir.
Yes or no? Great. So let's jump to the diagnosis. What's it? What it is? Stool toxin, right? So this is a stool toxin is one of the screening tests of Clostridium difficile infection. Number one. stool toxin or Clostridium toxin test is one of the screening tests for Clostridium difficile infection. The most likely diagnosis in this patient is Clostridium toxin, right? And the PCR is used to detect this toxin. Enzyme immunoassay for either glutamate dehydrogenase antigen or CAD is another screening method. So if you don't remember another, at least you must know that stool toxin test is for Clostridium difficile. We were talking about fecal lactoferritin. Let's see what is it. So fecal lactoferritin could be ordered if inflammatory bowel disease were being considered, like ulcer, right? Inflammatory bowel disease includes what? So it includes ulcerative colitis, right? But why we are not thinking which more often bloody diarrhea? Inflammatory bowel disease usually have a chronic course, not 4 days, 5 days after the antibiotic, right? So here what they mention, 4 days after antibiotic, azithromycin and ceftriaxone, bloody profuse diarrhea. This could be either in a months or years, chronic course, which is not in the scenario, right? It is also associated with the uveitis, extra intestinal manifestation. This is also another question in exam. Uveitis, erythema nodosum, pyoderma gangrenosum can be associated with inflammatory bowel disease, which is not the case in this scenario, right? So this is a few point against this, right? CT scan of abdomen. CT scan of abdomen is not a good diagnostic test. CT scan of abdomen is not a good diagnostic test for Clostridium difficile, although it could be used if the patient went to develop some complication of Clostridium difficile like toxic megacolon or abscess. In that case, you probably need CT scan, but for this, not. Blood culture. Blood culture are used to diagnose bacteremia, and that is or secondary to or causative or of various type of infection, example as endocarditis or abscess. However, bacteremia is rare in Clostridium difficile infection, and another step is indicated in the management of this patient. So blood culture will not going to help, right, in Clostridium difficile. And sigmoidoscopy would be indicated in suspected Clostridium difficile infection with negative stool test. So we have a stool antigen test or fecal antigen or fecal toxin test. If it is negative, then it could be helpful. Otherwise, not as a first line. It is clear cut, but it is not the best initial test. Sigmoidoscopy finding consists with Clostridium difficile infection, includes erythemus, febrile mucosa, and pseudomembrane with membranous colitis seen in a severe crisis. The procedure may also be indicated for suspected diverticulosis, but which is not the case, right? So that's it for it, right? So sigmoidoscopy is also not much helpful in context to this. Can anyone tell me what is the treatment of Clostridium difficile? Let's jump to the another questions. So this is all about the Clostridium difficile treatment. If somebody has a first episode, critical and non-critical. Second question, treatment same, treatment of Clostridium difficile. Somebody develop first time in
Vancomycin.
the lifetime, right? Patient is critical, patient is non-critical. Another is a recurrence of the Clostridium. You have treated with whatever the one XYZ drug. Again, after 2 months, patient coming and coming with the Clostridium, you need the stool toxin test. Again, it is positive. How you treat? Three, four question in one question. Go ahead one by one. First line treatment for Clostridium difficile, critical patients, non-critical patients. Go ahead, open for all. Anyone can answer. High yield, all high yield for the exam.
Vancomycin, sir.
Vancomycin, oral, IV, subcu,
Oral.
Oral.
vancomycin, oral. Those who answer oral, let me ask why not IV? We need to understand being a doctor. Why not IV? Anyone? Yes. Yes. Why not IV? Yes, Dr. Nisani Nafauti. Any comment?
Mostly
Oral?
it is an intestinal
Sorry.
infection, sir. Not in the
Sorry.
blood. It is a intestinal infection.
Sir,
So
acts
we
locally
Fine, fair enough.
more.
So that is probable the explanation. Fair enough. So let's see the literature. This is literature. It is not in the master of the board. This I all slide I got it from the journal. So before I present my class, I sincerely work and effort on each and every slide. That is how we get these slides, right? It is not in the book. It is from the journal. So 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 antibiotic therapy for Clostridium difficile in adult. Initial episode non-severe, fulminant means severe. So non-severe first line, forget about metronidazole. Those who have back in the mind metronidazole, it's no more a drug of choice. First line, lots of things. So oral vancomycin or fidoximicin. Remember two things in your mind, right? Oral vancomycin or fidoximicin, right? Second line for non-severe. This is non-severe, right? So non-severe, simple question. First line is oral vancomycin or fidoximicin. That's it. That is also oral. So oral vancomycin or oral fidoximicin. That's it. This is first line. When you, until proved otherwise, use this drug, right? Second line, when we supposed to use second line, when first line fails, we go for the second line, especially for the non-critical, non-severe patient, right? So second line for non-severe, if vancomycin and fidoximicin are unavailable or inappropriate or contraindicated, or there is an allergy of this drug, in that case only you use supposed to use oral metronidazole. Is that clear? Yes or no? Yes or no?
Yes, sir.
High yield question in exam, absolutely high yield. What how to deal with the patients who have fulminant CDI, clostridium difficile infection, fulminant or fatal or severe? First line, again you don't need to worry, oral vancomycin top the list, right? Considered adding IV vancomycin, considered, but oral vancomycin is the drug of choice. First line, you may not add, that's your choice. Considered means you can consider severe patient. In the patient with paralytic ileus, considered adding vancomycin enema, right? Patient, somebody say, "No, sir, I have paralytic ileus, oral cannot get absorbed, intestines are gone, intestines are paralyzed, nothing can be happen, hypokalemia, what to do?" Adding vancomycin enema, right? So vancomycin, but that what is the take home message? That means you cannot avoid the vancomycin, either oral or enema, but vancomycin is mandatory. This is for the non-critical and critical, first line and second line. So whether it is a non-critical, oral vancomycin, whether it is patient is critical, oral vancomycin, you may or may not metronidazole, and if the patient is paralytic ileus, vancomycin enema. Is that clear to everyone? Yes or no? Yes or
Yes.
no?
Yes.
Now comes to the recurrent CDI. First recurrence, right? If the initial episode was treated with oral with the standard dose of vancomycin, then you use the oral fidoxomycin, right? So that is the important take home message. So already you have used 3 months back, patient has a CDI infection, you used oral vancomycin, treated well, but now again 2 3 months patient presented, that is first recurrence, right? At that time, oral fidoxomycin. If the initial episode was treated with metronidazole, again either oral fidoximicin or oral vancomycin. That's it. If you were treated somehow where both the drugs are not available, it's not possible that everywhere you get oral vancomycin. Even oral vancomycin is available, but getting oral fidoximicin, even I mean sitting in the higher center, transplant center, it's a bit difficult. So we usually give oral vancomycin, right? If it is not available, vancomycin in your center or fidaxomicin, at least you can give some metronidazole. And subsequent recurrence, first recurrence, and then second, third, fourth, second recurrence, third recurrence, whatever subsequent recurrence, oral fidaxomicin is a drug of choice. That's it. So this is what the take-home message for Clostridium difficile. Is that clear to everyone? Yes or no? At least tell me yes or no.
Yes, sir.
Yes,
Yes
sir.
or no? Wonderful. So this 110% all question comes in exam. You will remember me in exam room, right? All 65 will come AML, ALL, CML, CLL, Hodgkin's, non-Hodgkin's, hairy cell leukemia will come, right? And also this all Clostridium difficile will also come. Let's discuss last more couple of questions. Now just check your cardiology little bit. A 55-year-old woman loses consciousness in the emergency department 1 hour after being admitted to the hospital for sharp acute chest pain and diaphoresis. There are no palpable pulse. Chest compressions are started. Medical history is significant for type 2 diabetes mellitus, and she had a breast cancer that was surgically treated 4 years ago. Prior to admission, the patient was on a long bus ride to visit her sister. Her medication includes tamoxifen, atorvastatin, metoprolol, metformin, and insulin. The cardiac rhythm is shown here. Which of the following is most appropriate next step in the management? Are you going to give intravenous glucagon therapy? Right? I'm interpreting for you, but in exam, nobody will interpret. Probably this patient has a very low glucose. So you must give glucagon, increase the glucose level. Patient is diabetic. Defibrillation, coronary artery angiography, intravenous epinephrine therapy, intravenous amiodarone, hypothermia therapy, intravenous dextrose therapy. Think of it. Think of it. See the scenario here. You have to apply your all expertise in scenario, as well as you need to look at the ECG, and you need to make some diagnosis, as my triad is always there before start. So what is the diagnosis? How you gonna investigate, or what are the investigation of choice and treatment? So now you need to know what is the diagnosis. First of all, this is your first job. Once you make your diagnosis, next step in the management would be little easy. Think of it, see, and then we'll discuss
Sir,
one by one. We
no
need to
palpable
exclude
pulse.
everything.
Yes, sir. So most
Yes, sir.
likely
Go ahead.
ECG shows us like pulseless electrical activity because there is no palpable pulse,
Okay.
and
So this is you pulseless electrical activity. That is what you mean to say? PEA?
that is correct, sir. Because of no palpable
Wonderful.
pulse.
Fair enough. So I'll keep your diagnosis likely PEA. Those who don't know PEA, it is pulseless electrical activity. That is one this comment from the our colleague. Yes. What else?
And as per ACLS guidelines, sir, for PEA comes into the non-shockable rhythm. So the option B has been ruled out already.
Okay, great. So I will rule out option B because it is a non-shockable rhythm as per the CLS guideline. So this is gone as per you, right? So what you do next now, because you have A to G options.
And when
Which
it
is
is
the most
pulse,
appropriate?
yeah, it is a non-shockable, so we must need to give epinephrine as soon as possible.
Okay, so epinephrine should be given as soon as possible. So this could be by you is the answer. Yes, so let's see what other experts are also saying, then we'll discuss. Yes, post your answer. Everyone post your answer. You can post your own answer. Doctor has given their his answer. You can post your answer. We are concerned with the explanation, not just the answer. Yes, Pratibha, what's your thought process? Yes, yes, Dr. MD Shadab Reza, what's your comment?
Sir, it looks like PEA, sir. So we have to give the
It's
epinephrine.
Epinephrine. Wonderful. So this is PEA. So electrical activity is there, right, on the ECG, right? You can see the PQRST, that is a wave, right? We can identify this is P, this is Q, this is R, this is S, this is T, again T, right? So some kind of activity is there, right? But pulse are gone. So it is called as a pulseless. There is no pulse, right? So let's go to the stem of the questions again. A 55-year-old lost the consciousness in emergency department 1 hour after admitting for a acute sharp chest pain and diaphoresis. So what is the diagnosis of this patient? What happens to this patient? Why he has acute chest pain and diaphoresis and lost the consciousness? Could be cardiac arrest.
Sir, cardiac arrest. Correct, sir.
Okay. There is a no palpable pulse, right? So where we supposed to palpate the pulse in ACLS BLS protocol? Which common artery they recommend in ACLS BLS protocol? Options are temporal artery, carotid artery, radial artery, or
Carotid,
femoral
sir.
Carotid.
artery. Carotid artery, right? So carotid artery is usually is easy. You can't jump from head to toe, right? So carotid is easy. You can do multiple things at the same time. Chest compressions already they started. Medical history, they have a diabetes, she had a breast cancer on this medication, rhythm is showing this. Why not intravenous glucagon? Because this patient is not suffering from hypoglycemia, so not required. Coronary angiography at this point of time is not required, right? Because patient is already collapsed. You need to give something which makes the heart starts immediately, right? Yeah, angiography is a treatment of choice in a acute coronary syndrome, yes. But emergency room, this patient is in emergency room. This patient has a acute chest syndrome, probably acute coronary syndrome. This patient has a cardiac arrest. So you generated the BLS or ACLS protocol because patient is now in the hospital, right? So you generated BLS start with the ACLS start with BLS. So CAB, earlier it used to be ABC. Few years back, ABC was the protocol for this CPR. So it is not now for CPRs, and CPR always CPR means cardiopulmonary resuscitation. Start with the CAB, chest compression, airway, and breathing. Is that clear so far? Yes or no? Yes or no?
Yes, sir.
Right? So this people are confused. I've seen the doctors who confuse, sir, when to give ECR, CPR. So I excellently created a acronym for them. CPR, the name of the CPR means cardio, means heart, pulmonary means lung, and resuscitation means you are trying to revive them. They are dead now. You want to make it active again. In right? So when to give cardiopulmonary resuscitation? When there is a no C for conscious. C for conscious, C for conscious. So no conscious, P for pulse. So no pulse. Pulse, no. Conscious, no. R means respiration, no. This is what I created. Probably it looks easy to me, right? So, so I am saying to my juniors, do CPR when you qualify for CPR. No conscious, no pulse, no respiration, do CPR. Is that clear? Yes or no?
Yes, sir.
So probably little easier for someone who are not good into the CPR, BLS, ACLS. So every patient should deserve the CPR when there is a no CPR. Means when the patient has no conscious, no pulse, no respiration, start CPR. And CPR start with CAB. Forget about ABC now. ABC is for general management. Patient, any emergency, any emergency, any emergency, right? Hypotension, septic shock, head injury, right? Hypovolemic shock, anaphylaxis. Start with ABC. When you want to start with CAB is in cardiac shock. When cardiac arrest, CAB, not ABC. Is that clear? When you want to start CPR, CAB, not ABC. Is that clear? Yes or no? So CAB stands for C means chest compression, A means airway, secure and maintain airway, and C for circulation. Is that clear? Yes or no? Yes or no? Are you getting me?
Yes, sir.
Yes, sir.
Wonderful. So this is CPR, all right, and CAB. So now let's go to the questions again. So intravenous glucagon is not required. Defibrillation. So defibrillation, there are two indications for defibrillation. One is ventricular fibrillation. If it is there, ventricular fibrillation, you must give the shock. It is a shockable rhythm. Second is a pulseless, pulseless VT. VT means ventricular tachycardia. How you differentiate from this ECG? If it is VT, I will draw the VT. QRS, 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 QRS. That's it. This is VT. Is that clear? Yes or no?
Yes, sir.
Yes.
Yes, sir.
Ventricular fibrillation. What is ventricular fibrillation? This is ventricular fibrillation. Hardly ventricular is doing contraction. This is the worst condition. Worst ECG of the globe is ventricular fibrillation. There is no bad ECG than ventricular fibrillation because ventricular fibrillation means death. Whenever I see in my emergency VF on any patient, I think this patient is dying in 5 minutes. Absolute emergency, absolute. Biggest emergency in the world is VF. No emergency is more worse than VF. If you find out any emergency which is worse than VF, do let me know. VF means death. You are seeing the death. VF means you are seeing the death. Any other emergency you get some time. 5 minutes, 10 minutes, 20 minutes, 30 minutes. VF means 1 minute death. 1 minute death. That's it. So this ECG you need to respect this ECG and do as soon as possible. Right? So this is not a VF. This is not a VF. This is not a VT, isn't it? Yes or no? So defibrillation will not help to this patient, as rightly gentleman told. Intravenous amiodarone is a second line drug where the arrhythmia cannot be controlled. You can give the right amiodarone. Hypothermia at this point of time not required. IV dextrose not required. We are not dealing with hypoglycemia, right? So this is the thing. So first you do it, stabilize the patient. Once patients revive, right? You can go for the angiography and then angioplasty as well, PCI, called as a PCI, right? So context to this question, right? The most appropriate answer is intravenous epinephrine. So in BLS and ACLS protocol or ACLS protocol, right? Can anyone tell me if you have such patients, right? So say for example, you are going for the morning walk. Somebody is jogging with you. You don't know who is that gentleman, and all of the sudden he collapsed. He has no CPR, means no conscious, no pulse, no respiration. What you do now? You see somebody is fall down in front of you in the garden, right? What you do? Looks like this patient or that jogger collapsed. How you supposed to generate your things?
So
Anyone?
check for the
Hi.
I need exact as per the protocol, guideline protocol, because this is hundreds of question with CPR and ACLS and BLS and
I
amiodarone
have
and
to start
epinephrine.
the CPR and call for help.
First call for help, then start CPR.
And start the
So,
CPR.
so you will ask for the help or you won't ask for the help.
First call for help, then start CPR.
Okay, so you call for the help, right? So you call for the help, and what you tell to the person if you are asking for the help. So what exactly the word you mention to the people who is like going to help you? What
To
are
carry
that
the patient for
sentence?
hospital,
Sorry.
to carry the hospital patient to the hospital for help.
Okay. Okay, so hospital is sick, for example, half an hour. Nearest hospital is half an hour
Yes.
from your place. What you will do?
So first we'll check if patient is breathing or not. If breath is not there, first we'll ask for help and ask a person to call for ambulance and tell them to bring ETD machine. And then we'll check their breathe. If till count 10, if breath is not revive or not there, so we'll start for CPR and breathing as well.
Excellent. Wonderful. So there is a protocol. There is an absolute international universal protocol. You must know it. This is universal protocol. I got it from the recent guideline book, right? So what are the steps? See, 1 to 9 step. I will tell you one by one, right? It is excellent, important, and hundreds of question with this, right? Check responsiveness and call for help. First step is call for help. Why you never ever perform BLS alone, basic life support, airway compression you cannot do alone. You can do alone, but you get fatigue. So in 5-10 minutes you are done. You also need some rest, and patient will die. So first of all, you ask for help, right? And check for responsiveness. How you gonna check the responsiveness? Are you all right? Are you okay? Are you okay? So this is a patient. Tap very very hardly on the both the shoulder. Hey, are you okay? Hey, are you okay? Hey, are you okay? Is not responsive. Means check the responsiveness. Is not responsive, right? Then call for the help. So first check the responsive. If it's collapse all of the sudden in front of you, anywhere in the bus station, on railway station, platform, in a hospital, out of hospital, garden, anywhere. This is the standard universal guideline for BLS. So check for responsiveness, call for help. What you do while somebody coming for the help, go to the second step, open the airway, right? Right? So how you open the airway? Open the airway and assess the breathing, right? Where you supposed to check carotid pulse, carotid, right? If you are not trained, you are non-medico, you can do the carotid as well. I mean radial as well, right? If you don't know, because layman probably may not know where is a carotid. But if you are a doctor, right, right, we are. I mean, in front of us, we are all experts, so we can check the carotid. So open the airway and assess the breathing. So she is opening the airway. How you open the airway, right? You chin lift, right? Jaw lift and chin tilt, right? So you by this extending the neck, here you can see the neck is normal. Second, you can see the neck is extended, right? So airway will open. You can inspect. Third step, right? You already call for the help. With help, ask 911 and AED. AED is automated external defibrillator. Those who don't know what is AED, AED is automated. A stands for automated, right? E means external. It is outside the body. That is why external. And function is a defibrillator or defibrillation or defibrillator, or shortly people called as a defab. Get the defab in emergency, right? So this is AED. This is AED, automated external defibrillator. It's a small compact devices, right? You can carry like a bag in your hand, and you can go anywhere, right? So AED, right? Then next step is 30/2 compression. 30 compression, 2 breath. 30 compression, 2 breath. So here you call, ask for the help, check responsiveness, ask for the help, open up the airway, right? Call 911 with the preferable AED until and unless the AED arrives, or until, right, until it reaches to the patient side, you start compression with the ratio of 330 compression, 30 compression, 1, 2, 3, 4, 5, like that. You this is the exact position of the compression. High hands are completely straight, compressing the lower end of the sternum will come on that point. And then while you are compression, and then airway, 2 breath, 30 compression, 30 chest compression, 2 breath. While you are giving the breath, your eye should be on the chest wall, whether there is an appropriate rise in the chest wall or not, right? That is there. And then once the AD arrives, that's the next step, right? You continue. See, this lady is continuing the CPR, right? So while applying the pads, right, it is called as a right upper and left lower. This is how heart is like a sandwich, right? This is a pad, this is a pad, and heart is in between. Heart is in between. This is called sandwich. So this is usually at the right upper limb. This is left lower limb. This is how right upper, left lower. So like that, heart should be sandwich. Heart should be sandwich. Here one pad apply, another pad here apply. In between there is a heart, right? So there are two pad which going to deliver the shock to the patient by AED, right? So you must see there are lots of videos available on YouTube, right? How to operate the AED. It's a small 2-3 minutes of video, but very interesting. Will clarify your thought process. So you do 30/2 compression. The lady who is doing compression and breathing, she continues CPR while this gentleman is applying the pad, and only CPR should be stopped. No CPR, only the condition where you should not do the CPR at the time when the AED is analyzing the rhythm. AED is analyzing the rhythm. There are two things in rhythm, just for your knowledge: shockable rhythm, non shockable rhythm. Let me tell all gentlemen, you don't need to apply your mind and brain to deliver the shock. You just need to open up your ears and listen what AED says to you. AED says it is shockable rhythm, deliver shock. This is how computer generated they will tell, right? So you need to just follow the instructions of AED. You don't at all need to apply your mind. It is automated. That is why the name comes automated. You don't need to do anything. Automated, everything will be done by the defibrillator, right? And it is outside the body, that is why it is called AED, right? Internal defibrillators are also there, right? So this is how it works, right? And if it is a non-shockable rhythm, if it is shockable rhythm, give shock. If it is non-shockable rhythm, start CPR. See, is this gentleman now starting the CPR? Is that clear to everyone? Yes or no? At least tell me yes or no. I'll try my level best to make your thought
Yes, sir.
process bit
Yes,
more
sir.
clear,
Yes.
right? So
Yes,
this
sir.
is the protocol. This is the protocol. You don't need to jump on from 1 to 3 and 3 to 5. 1, 2, 3, 4, 5, 6, 7, 8, 9. All important, all they will tell you, right, that you assess the patient. There are hundreds of questions from one picture. They will tell you, you check the responsiveness. What is the next step? You did the airway open. What is the next step? You ask for the 911 for the help. What is the next step? You started 30/2 compression. AED arrives, what will you do? Then don't do the once AED arrived, apply AED, look for the rhythm shockable or not. Another question in exam, while AED is analyzing the rhythm, are you going to do CPR or not? Answer is not. No, you don't need to do CPR. Only time, right? While AED is analyzing the rhythm. While somebody is applying the pad of the AED, are you going to do CPR? Yes or no? Answer is yes. Applying the pad, you continue the CPR. Analyzing the rhythm, don't do the CPR. Is that clear? Yes or no?
Yes.
Yes or no?
Yes.
Wonderful. Brilliant. Brilliant. So this is CPR, I mean, sorry, BLS, ACLS is a part of all Middle East country requirement. So it's not mandatorily at the time of DHA you must do it. But if you can able to manage it after cracking DHA, HAD, MOH, OMSB, SMLE, QCHP, Bahrain, Qatar, or any country exam, better to go with the BLS, ACLS certificate. And you must do not with the local body, you must do with the AHA. AHA. What is AHA? American Heart Association. AHA is American Heart Association. I did it. It's a 2 years validity course, right? 2 years validity. And this is globally accepted, right? From AHA, right? So just check it before starting is BLS, ACLS. It is a 3 days course, 1 day BLS, 1 day BLS, and second and third day is ACLS, and last day they will AHA will take your exam. For your knowledge, passing score is 80 to 85%, right? If you have 84, you have to appear again for the course. So 85 is a passing score, and once you do it, you get a AHA certificate. It's like a smart card which mention your name, where you did this, and unique ID number which can be checked from any part of the world, and it is written AHA, issued by AHA, like that. Just general. I did it from AHA. So this is a basic information I'm gonna give you. So just keep in mind for this BLS, ACLS, probably not required at the DHA pass or eligibility letter, but once you join any hospital, they probably need it. So either you can do it in Middle East or in your country. Both are okay. So just try to manage it. So answer of these questions, the best next step for this patient is a PEA arrest. PEA means pulseless electrical activity right. So the next best step for the patient who is PEA arrest is administration of epinephrine. Again, important questions. Epinephrine. Can anyone tell me what is the indication of epinephrine? Epinephrine, where you can use epinephrine? Question in exam.
And
One is
anaphylaxis.
so excellent. So epinephrine, two things we'll see: anaphylaxis and ACLS protocol, or cardiac arrest,
Cardiac arrest.
ACLS protocol.
Yeah.
Head to head comparison. Drug is same. Drug is epinephrine. I want to know route of the drug administration, dose
Subcutaneous.
of the drug administration, dilution
Sub-
of the drug administration. Three things is different. Same way, route how you going to give the epinephrine in ACLS protocol. What is the dose of epinephrine in ACLS protocol? What is the dilution of the drug in ACLS protocol? Drug is same for both. You start now. Anybody can start now.
In ACLS, it is IV 1 raised to 10,000.
Okay, so ACLS route is IV.
Yes.
Dose is 1 as
1
to
mg. 1 raised, dose
1000,
is 1,
1000, 10,000 or 1 lakh,
10,000.
10,000. Dilution dose. I mean, this is dilution. What is the
This is
dose?
dilution. Dose is 1 mg every 2 to 5 minutes.
Okay, so and frequency 1 milligram every
1 mg, 2 to 5 minutes.
5 minutes. Wonderful. Same thing. Route epinephrine anaphylactic shock.
Root IM,
Yes, IM. Dose.
dose 0.5 mg. Dilution 1 raised to 1000.
Is that clear to everyone?
Yes.
Drug is same, but see, everything is changed. Here IV, here IM. I want to emphasize on that. That is why I raise this point, because we are confused, right? This is all high yield point for the exam. So never ever get confused. Here one has 10,000 dilution. Here one has 1,000 dilution. Here intramuscular, here IV, right? Here the dose is 0.5. Here the almost double, 1 milligram every 3 to 5 minutes. Is that clear to everyone? Yes or no?
Yes, sir.
Excellent. Wonderful. So last but not the least, my slides. So this is what the shockable versus non-shockable rhythm, as we already discussed. Defibrillation possible when possible. Defibrillator, ventricular fibrillation. This is what the thing I have said. Chaotic rhythm. There is no specific, and this is already I draw it as well. Ventricular tachycardia. Why ventricular? Because this is QRS. There is no P wave. No P wave. Can you identify P wave? No P wave. Only ventricular. Ventricular activity, basic of ECG. This is P wave. This is Q wave, R wave, S wave, and then T wave. P wave is atrial activities. So in simple language, atrial. QRS is a ventricular activity, right? So this is QRS, ventricle. Is that clear? So it's a ventricular tachycardia, right? So this is all shockable rhythm. Asystole, flatline means death. This is death. Flatline is death, obviously. This is death. None other, right? So before, when we declare anybody death, what we do? How we confirm? We do ECG, flatline, no electrical activity, done, right? And pulseless electrical activity, right? So electrical activity is there, but pulse are gone. Pulse, no pulse. And that is why it is called as a pulseless electrical activity, which is non-shockable rhythm. Shock is not possible here. here. Is that clear? Yes or no? At least tell me yes or no.
Yes, sir.
Yes, sir.
Wonderful.
Yes, sir.
So this is what the protocol is. I already mentioned you, explained you. So just keep in mind and read it through the standard guideline of ACLS and BLS. So that's all. It's a hour and a half. I'm speaking probably with full energy and most of the high yield points. So before ending up my session, I would like to have quick feedback on this session. How did you enjoy it and what was the new learning? I would be glad to have your little feedback. Yes, please. Yes, please. I would be glad.
Thank you, sir. It was a very excellent session.
Wonderful.
Sir,
What
of
was
course,
the
it is
new
very
learning?
energetic and very valuable session. Of course.
Wonderful. Thank you
The
very much.
only reading is making you just a book to understand, but attending your lecture is making you feel like a child, like an enthusiastic way we can learn. So it make us happy to learn by your lecture.
Thank you very much. We have all experts in the team, so I'm not the one. There are also excellent speakers like me. So enjoy all the sessions, everything. So I would love to have a mock test on every Sunday. So stay tuned with me, right? So I mean, I just try to make you guys understand how to prepare. You understand what we do? We usually mug up the things. We try to understand, but if you understand the things, how you diagnose, investigation, treatment, though it looks small thing to you, but if you practice, believe me, it would be great help to you. It would be
Definitely, sir.
great
It is
understanding to you.
not only for examination preparation. It is for practical purpose also.
Yes, sir. That's correct, sir. That's correct, sir. That's correct, sir. Yes, anything, Dr. Bhavya? Any comment? Pratibha?
Yeah.
Hello,
Wonderful, sir.
sir. It was a very
Wonderful.
informative lecture. Thank you very much, sir. This was my first session. It was very
Wonderful.
good lecture.
Thank you very much. Yes, Akbar. Yes, anyone?
It was a
Hello,
great lecture.
sir.
Your
All the
explanation was very good and very nice. Whenever I attend the classes, there is sometimes there's some confusions in the questions and how to approach and how to deal with the confusion. And your teaching approach mainly for each and every question is very much informative and very much helpful, sir.
Thank you very much for your kind feedback. Anyone? Last but not the least, yes, Kainat, any
Very good, a
Haifa?
very excellent session, sir. Hello.
Yes, yes, please.
A very
Yes,
excellent
yes.
session, sir. It is like every time when I attend the class, I feel I'm learning something new. And the way you explain it is like amazing, sir. Really.
Thank you very
Thank
much
you
for
so
your
much, sir.
motivating word. Honestly speaking, I
Thank you,
do
sir.
a lot of hard work before presentation. Believe me,
Yes, sir. Yes, sir.
to make it
It
more
is like
interesting. I
very
mean,
helpful for
Yes,
us
sir.
otherwise,
It's,
when
it's
you
otherwise
really
everything
explain.
excellent,
is in
sir.
the book, na. Otherwise, this is all in the book. But I mean, if you just read it, it won't help you much. So I do and try my sincere efforts every time to make it more interesting and with a take-home message, so you learn more.
Definitely, sir. No doubt.
we can see that in your slides. It's
Thank you
obvious.
very much. Thank you very much, sir. Thank you. Okay, so thank you very much. Enjoy your Sunday. Keep in touch and do let me know for any help. Thank you very much, all. Thank you. Thank you,
Thank you, sir.
Nagin.
Thank
Thank
you,
you,
Thank
sir.
you.
sir.
Thank
Happy
Thank
you.
you
weekend.
so much.
Take
Thank you.
care.
Thank
Thank
you,
you.
sir.
Bye bye. Bye bye. Thank you.
Thank you, sir.
Thank you.